So thank you so much, Abhikshita, for that introduction, and respected Dr. Manisha Kiran, Dr. Ranjit Atlay, and thank you for the both RINPAS and the Association of Psychiatric Social Workers in India for facilitating this session, and it's my privilege. In fact, last 2 years I wanted to join, and some reasons I couldn't join this program, but this year I was sure if there is a chance I will be joining. And this is a favorite topic. Am I audible?
Yes, sir, you are.
Yes, thank you. So this is a favorite topic for me to address all of you, because the geriatric care and psychiatric social work services, it's an emerging area, and it's going to be a rewarding area, and we can do a lot of things. As I understand the medical care, the importance of medical care in aging, our social care or the psychosocial care is also equally important. Like many times in our discussions with the medical team and our fellows clinical psychology team, I used to tell that if you give the 100% medical care and 100% psychological care, but if you cannot provide the psychosocial care, definitely the overall outcome of care will be zero. So when psychosocial care becomes zero, the medical care and the clinical psychology care becomes zero, because it is multiplied. Because when our number becomes zero, all other number also will become zero. Why I'm telling, confidently I can tell you, say an aged person living with dementia, if you do not provide the psychosocial support and care by the psychiatric social work team or any members of team, what's going to happen? The person will not be having no quality of life. There will be early death will be there. So a lot of issues are associated with psychosocial care, which with that we can enhance their quality of life, recovery rate, and things like that. As students, you might have already seen in your wards these issues like the aged patients and their issues. We are going to discuss that in this presentation. So see, aging among elderly population and associated mental health psychosocial problems are addressed in geriatric mental health services. Aging among elderly population, that is, the elderly population is defined 60 plus as per the Maintenance Act, which we'll be discussing little later. And associated aging also induces certain mental health problems. And because of both the structural changes in the brain and the functional aspects and the stress and other lifestyle disease, lifestyle related impact on the brain and behavior. And these problems are usually addressed in the geriatric mental health care services. So if you see the relevance of this topic, so you take any diagnosis which you know. So aging itself, it's a psychosocial issue, and Helpage India has estimated around 10% of population. Not earlier census is 8+% in 2011, but by 2011 their estimation is 10%. That's almost 14 crore population are aging. That aging itself, you know, that the decline in their physical or the social or the cognitive functioning, and that can precipitate a lot of issues in their relationship and their quality of life. And the increased prevalence of mental illness, especially depression. This study is a kind of systematic meta-analysis review, has estimated 30% of population above 60 have depression. So you know that how many of them are seeking help. Many of them do not seek help. They suffer silently. And personality change, aging associated personality change, stroke, post neurological problems, or the during the neurological problem like stroke, there's a high chance for personality change, and its impact on behavior, and mild cognitive impairment. This is another major problem we many times we ignore, because when it is dementia, due to the memory problem, due to the impairment in cognitive functions or behavioral problems, associated behavioral problems, it's very clear. It's very clear we can understand this person is different from a normally aging elderly. But many times mild cognitive impairment, like difficulties in judgment, difficulties in selecting solutions, problem solving, seeing difficulty to see the others' perspectives, all these things create a lot of adjustmental issues in their life, be it in workplace or be it in family, be it in the community where they live. And we also need to be very mindful the disability associated dementia. The dementia it's another systematic study estimated among 1,000 population, nearly 20 people are having dementia related issues. And also the World Alzheimer's Association has estimated that more than 4 million of Indian population have dementia. So whenever since people know that I am associated with the geriatric care, I do get a lot of calls related that facilitating care centers, long-term care centers for dementia patients. Imagine that, do we have facility for 45 lakhs population who have this kind of dementia problem? We do not have. We have very few resources, daycare centers, long-term care centers. And since we have very few centers, almost all these centers are costly. I do tell job, sometimes I may take retire and go to Kerala and take care of maybe 10 dementia patients. That will be 4 times rewarding that what I do now, because I can demand the cost of care where caregivers are ready to pay, because it affects their quality of life. They lose their, many times people quit job just to take care of the people who are dementing. And why dementia is very important for psychiatric social workers is, dementia is a neurological diagnosis, but associated behavioral problems, and it's a kind of needs multidisciplinary psychiatric care, and we do play the major role in that. And decreasing support. So if you are preparing for exam, this point is very, very important. Decreasing social support due to not people are not losing values and all. So earlier, if you know the structure of a family where 8 to 10 children, even if some of them cannot adjust with the head of the family or an aged person, there will be 1 or 2 persons will be there in the family, both male and female children, who can manage the aged population. And then you know that this agrarian or agriculture centered, or the kind of life which we had, a lot of prominence we used to give for elderly, especially the rich Indian culture with a lot of festivals and the lot of celebrations. And in fact, we believe, the Mada Pida Guru kind of is equivalent to God. So a lot of importance was there, but once size of family actually comes down, all these principles will be disrupted, and there are a lot of disintegration happens. That's a major issue. And with the urbanization, you know that the cost of living, cost of care, cost of healthcare, out of pocket expenditure for healthcare, all these things also had a huge impact on the mental health of and the healthcare or overall well-being of elderly. And migration is another aspect. Migration, I'm not speaking about the what we see trend in Kerala, Tamil Nadu, or some of the states where people migrate out of the country. I'm not speaking within the country. Rural to urban area migration also has a major impact. Why this kind of things cause impact is, once we cross certain ages, our ability to adapt with the situation, ability to learn with the situation may be compromised with our non-communicable diseases like diabetes, hypertension, and other issues like the growing number of neurological disabilities. And so in that context, if you see most common mental health problems, what we see here is anxiety, depression, late onset psychosis, and behavior problems due to the dementia. And you might have seen also all these problems in this thing. And one of the things I feel that the access to internet, access to the digital media, visual media has not decreased the anxiety of elderly. In fact, it triggered the anxiety of elderly, and it creates a lot of confusion. So, for example, any be it a television channel or a radio talk or Google, if you try to search for any disorders, it can only precipitate the anxiety among elderly, because everywhere one clause will be there: aging is a risk factor. During COVID-19, how much our elderly suffered, we all know that. In fact, it has become a taboo. The person elderly, if comes out, it shows that the family members are not caring. So the information which is circulated for the various purposes, for the advertisement of the healthcare products, and we know that it's not positively contributing the welfare of elderly. In fact, it induces a lot of health anxiety and unwanted doctor shopping, and its impact on their resources also is a major concern among this population. And common psychosocial problems like health problem associated distress and loneliness. In fact, the loneliness is a silent killer among the any kind of population, but the aged population, it's a kind of a major issue. Feeling lonely, or lack of friends and lack of somebody to relate and connect and cherish, and then feel good factor or belongingness factor. This is very high among elderly. What medicine we can give for loneliness? And in fact, actually, we need to strengthen their social network, the social ties. A lot of inhibitions will be there due to the unemployment, due to their own social status, the restrictions from family, health conditions, health impairments. We had a beautiful study in collaboration with the Manchester University, where we found that the hearing impairment can cause distress to the elderly and can precipitate the early onset of cognitive impairment. Many times, the neglect what elderly experience in terms of visual impairment, hearing impairment, mobility related issues significantly affect their overall well-being. Now, I need to tell, I usually tell in my all aging related talk, we need to plan. There's a lot of planning is required in healthy aging and protecting mental health. For example, if you divide the life into 30 years, like that, what I mean is that first 30 years we spend for our education, getting a job or getting a partner, the children, childbirth, and things like that. And that's the time we also we can pick up alcohol use, tobacco use, less exercise, body weight, and all those things can happen. But if you invest well, the next 30 years, that means 30 years to 60 years. That 60 years, if you can have better quality of life if you invest with the healthy habits, physical activities, and the good relationship network. Then what happens with the next, if that 30 years and from 30 to 60 years, if you have a healthy circle of relationship or a good work environment, and then good source of income and the, good investment on health through the various kind of physical and social engagements, and that's going to predict your next 30 years. That is 60 years to 90 years or 60 years to 100. But this plan, unfortunately, we are not very familiar. But all developed countries, they have products, programs, policies, and social workers availability. And the mental health care system is also very sensitive to ensure these transitions and ensure the quality of life. There comes one of our important role, the planning the aging process, and people benefit. And that will create a kind of clients for us, even when you consider the private practice or practice in medical colleges or general hospital settings. And the hopelessness, you know that it's not really associated with the depression or anxiety or the any other mental health conditions. Hopelessness itself as a phenomena, it's very high among elderly due to the lot of situational factors. Some of the factors can be solved through easy way. One example is senior citizen forums. Especially in Bangalore, I have observed that those who are part of senior citizen forums or volunteers groups or Lions clubs, and the hopelessness index is low. But those who are deprived of this kind of social circles, the hopelessness index is very, very high. So we need to be mindful about these issues and elder abuse, various kind of physical, emotional, financial neglect, different kinds of elder abuse. And this cannot be actually treated as such. Elder abuse itself, first itself, we need to ask, identify, and empower the elderly to prevent that. And also sensitize the people who are engaged. Many times, example, best thing is cognitive impairment. So if the family members do not recognize if it is a cognitive impairment, it is very high chances there is a chance for elder abuse. And then poor social support associated with that. And geriatric mental health care services basically our focus is home-based care, means enable the caregivers to provide the care at home for that what they need. So team members actually together decide also individualized care. So for example, everybody, any person with dementia, we know there will be caregiver burden will be there, burnout will be there, and some associated kind of family dynamics change will be there. But it is not same. There will be some variations in individual to individual. One example I can tell you. We had a caregiver. This is a published paper also in the Indian Journal of Community Medicine. One of our caregiver was she's the mother is also disabled. The spouse was disabled. So the caregiver patient's child was a kind of studying graduation. So we understood that if you do not provide, and she was about to quit the course because of caregiver burden. So then we understand that the need is the daytime, if the person is engaged, like in a daycare center, this child can continue the education. So see here, just in adding a facility of daycare service and convincing everybody its importance, and the team also agree or promote that decision, and that individualized care plan make a big difference in the quality of life of both caregivers as well as the person's life because of the trained care by a trained caregiver. Another key focus is caregiver partnered care plan. So this is another initiative by, again, Manchester University. We had also published papers in Frontiers in Neurology. So what they speak is the caregivers can contribute not only in making a care plan, they also can tell us what is the area we need to do research further. They also can tell that some of our products impact, and they can also narrate the associated issues. And who will partner with the caregiver? Usually our clinical settings, you know that 30-40 patients, building partnership with any individual, it is very difficult. It's more of a kind of prescription based or a individual therapy sessions based. For building caregiver partner, you need to have whatever social work skills we have learned, like how we build relationship or home visits or kind of telephonic sessions and crisis contacts, and then facilitating resources, whatever we can do, we need to do to build this partnership. And many times our caregivers profile, that even if people who are educated, when we are emotionally aroused, our analysis of problem may not be correct, and it can affect the care plan. And you yourself can recollect when you involve in care of your parents or grandparents, how emotions are triggered. Even if a cognitive impaired person comments on that, you are not a sincere person, you don't allow them, or you don't give any importance for their life, how much we emotionally we are disrupted or not disturbed, and how it creates impairment in our judgment. So it happens. So it needs a lot of supportive as well as the sessions. Like maybe we can even use the cognitive behavioral approach for addressing this kind of issues and then building partnership. And major challenges, other challenges are chronic health problems. Like if a person with schizophrenia in a young age, usually their profile will be, other health profiles will be fine, or this people with depression or anxiety or OCD spectrum. But here the person also are vulnerable to develop. Also, they may be suffering the health problems. So it's very difficult to differentiate the mental health problems and the chronic health problems, induced distress, and then the overall disability. And social withdrawal is another common factors. You know that the major two theories like social disengagement the theory, or the continuation of activity theory, both speaks there is a chance for the aging population, there's a chance for disengaged. So that's another major issue we need to address. The cost of care, burden of care, I have already mentioned. Let's go ahead. And then we also need to have another framework. Are there really only people who are suffering people? Are they not contributing anything for society? When we analyze the person, people who have even dementia, they contribute to society. One of the concept if I wanted to share is the presence of elderly in family helps a lot of intergenerational bonding, and it can act as a kind of the stress reducing factor. It can actually enhance the bonding among family members, because the bonding in family members, as you all learn in family therapy, if there is a common goal in life, like why families are continuing their life, children, or the financial needs or emotional needs, caring elderly can be another common goal in the family. So this elderly's presence can be a kind of binding factor in the families. And grandparenting, and if you actually calculate the total service of grandparents, it will be coming in the billions of rupees, because in urban cities we know that how much we need to pay. We do not get a person whom we can trust, who can take care of our children as a paid caregiver. It's very difficult, but still, if you calculate the contribution of the grandparents in caring grandchildren, like that, if you take in any society, the elderly population contributes significantly towards the progress of family, community, and the overall nation. And I have already mentioned this. And multi-generational families, it's a reality. But we say that, so nowadays nuclear family, that what multi-generation family you are telling, but you know that digitally multi-generation families again revived. Even if I am here, my parents in Kerala or in Delhi, wherever, their contribution, their involvement in your life actually have been doubled in last 1 decade because of the digital technology and the other factors. So multi-generation family, whether it is online or in person, it's a reality. And a lot of benefits are there. We need to speak about these benefits to reward both. So for example, the caregiving without resources can induce the caregiver burden, depression, anxiety, and the loss of employment and things like that. But at the same time, if you can channelize care resources, definitely a sense of purpose in the life can be established. The prevention of, like how I was doing in my previous role as a substance use disorders, the presence of the elderly care population in the family can reduce the risk like addiction, divorce, and then the risk for suicide, especially among children and the teenage, and a lot of social control which they bring for families. and what the caregivers needs. This is one of the favorite thing which I from the beginning of this, whenever I associate, I understand that the elderly, the person who is having mental health problem, need a lot of support. They may like to have some information, and they also need skills. But the same way, the caregivers need a lot of support, informations, and skill. And the skill, if you ask me, like a small skills, like how to speak with elderly. Like recently, some project, I asked the project, the people who applied, how to speak with elderly. You can also reflect, do we know about how to speak with elderly? How to handle an aggressive behavior in elderly? How to express love towards elderly? How to build some hope in elderly? How to motivate an elderly to eat food or drink water or ensure self-care? How to involve elderly in a routine affairs of family, and how to say no to elderly, because the many things they will ask you to do, and how to say no to elderly politely, how to handle our own nonverbal behaviors when we work or live with elderly. So a lot of scope is there. If you ask me, the skill building itself, you can give 12 sessions to family members. Just skills building. And information you can give for 3 sessions. And support you need to give, I think, countless support sessions. I still remember one of the elderly, that was the elderly person of my adult psychiatric patient's father, suffering from depression in the while aging, and his spouse, another elderly, she's also elderly, the father is older elderly, mother is also elderly of my patient. So this mother was discussing with me about the symptoms of depression of the father by the time he was about to hang himself in the upstairs, the another room which is in the upstairs. So in while giving listening her difficulties associated with the depression of that father, I just asked the patient's mother, where is he, the person, where is he? So the mother told, person is in upstairs, but he was very upset. And I asked another question, can you just go and see what he is doing? She just went up and saw that he was about to hang himself. So this is a scenario. So how to prevent suicide among elderly? So how to prevent a kind of a person who is dull and down and depressed? And how to de-escalate, a kind of normal verbal conflicts. You see that hundreds of skills they need, caregivers needs, and then the other family members gives. If you see also family, there will be the different levels of caregiving will be there. There will be a person who is a significant caregiver, and there is a person who gives break for significant caregiver. There is a person, maybe providers like resources. So all of them need services, and that's how we can plan. And a role of treatment team in care plan. That's also we need to be very mindful. Our role, as I told at the beginning, I do not have any kind of dilemma about our role. Role is very clear. Social care plan, the social risk factors identification, including the social plan. When I am saying that mind and the surroundings, mind and situation, its conflicts only create social issues. So you need to know how to manage mind, means thoughts and emotions and behavior and memory and things like that. And also you need to learn how to handle situation, the mind and situation. But the how we can understand mind and situation interaction, brain we need to know. And there comes the importance of not only psychiatrists and psychologists and social workers, there comes the importance of neurologists, occupational therapists, nurses, paid caregivers, and then all welfare systems, both governmental and non-governmental. Many NGOs, they do wonderful job in elderly care, like Helpage India, uh, like that associations. So PSW have a major role in care plan. You need not hesitate to take up your role. Every elderly needs a care plan, social workers care plan. It can start with psychosocial assessment as you do in the other settings, and the elements what you can look forward in the assessment: profile of both individuals profile, families profile, challenges experienced by individual. Challenges is not only the symptoms, overall challenges in the life of elderly and families, available resources for family, opportunities to facilitate the resource, the scope for individual and family centered the therapeutic interventions can be looked into. And common interventions, a lot of similarity you may feel with the other things. Other interventions, psychoeducation is mandatory thing, and caregivers support groups. Individual sessions are also mandatory for caregivers. Family sessions are important. Behavioral management of the individual is important. Engagement in activities are important. Facilitating formal care is important. Facilitating disability benefits are important. And I think yes, I mentioned already individual sessions. Individual sessions are equally important like family sessions. Sometimes what happens, we have a myth, we focus little more on family. We do not engage the individual. But if you do not engage the individual, what we learn in family therapy, we lose the neutral position. We do not get the alternatives or alternative hypothesis, and we go with the caregiver, and caregiver can happily get endorsement for their elder abuse behaviors or maladaptive care with the care techniques. So it's always better to have both individual sessions with the patient and in family sessions, individual sessions with the caregivers, and joint family sessions, and group sessions also for more of a kind of empowering or learning them among themselves. And the key principles to work with elderly. This is from my experience. Last many years, I have observed that you need to have time. And you need to give time. If you just speak for 2 minutes, 3 minutes, or 5 minutes, 10 minutes, they do not like. And I feel that their business is not dealt well. So you need to have time and give time. And then you can ask me how long. So how long, if you ask me, even if you give 2 hours, they're ready to speak and share. But you can plan accordingly. Ideally, I feel that like 45 minutes to 1 hour. Like how much time it takes for cardiac surgery or brain surgery for a single patient, they take 3 hours, 6 hours, or even a day. So here also time matters. And it is that importance of time is important. And the subsequent sessions can be short, but still time matters. And you need to listen to them like any other therapy sessions. Empathy is very important, not only for verbal empathy, non-verbal empathy is also very important. They're very good in observing your readiness to listen or proactive involvement, and explore their choices. Like in any other sessions, they're the masters and they know their needs. We cannot inject or implant our healthy aging package in their brain. So understand their situations and choices and then help them to plan. Respect. Even if you're going to kill them, if they don't mind, but if you provide respect, they themselves will guide that where you can hit and kill them. So that much the word respect has a huge importance in the geriatric care process. And social workers, we need to be mindful in this regard. Sometimes they may tolerate the doctors who do not respect, but still they won't come for next consultation. But we do not have any options. Learn to respect verbally and non-verbally, and stand for their rights and dignity. That's another thing will attract the clients to us. The moment they know that we give priority for their dignity, their rights, and they understand that, and speak and promote the elderly friendly policies and programs. That's another thing. This is another beautiful weapon which we have is the maintenance and welfare of parents and senior citizens Act 2007. And it is beautifully modified in Modi's team in 2019. As per the act, many of you are aware about this act, but what I like is the parents have equal rights like any other family member. And if you try to neglect, they can go to the taluk level revenue divisional officer or first revenue divisional officer, is a Tahsidas or taluk officers or that first the sub revenue divisional officer. Just write in a paper, I'm not well, it's because my children are answerable. Children means not only son, daughter, no, son, son-in-law, daughter, daughter-in-law, grandchildren. If none of them are there, whoever is going to inherit their property, because the person who is not married, then court knows whoever is going to inherit, or this revenue divisional officer knows that whoever is going to inherit, they are liable to provide the care and quality of life. Even the person has not contributed anything to them, because some people know that they have not contributed anything to their family, but still the children and grandchildren are, and the in-laws are, son-in-laws and daughter-in-laws are supposed to take care of the parents and senior citizens. And this and associated also a lot of mandates on government to establish the old age homes, policies to ensure the safety, security. So a police station also you can confidently go and speak. The moment you know the maintenance and welfare of parents and senior citizens, the judges are also very, very sensitive. And how we go further, like now towards the end of our discussion, care centers, both long-term and daycare centers, it is a need of the hours. And all these care centers, who can lead? Psychiatric social worker can become either the owners of care centers, or the care home chief executives, or the therapist, or the kind of consultants, whatever it is. So there is a huge scope for these care centers, and we have very, very less care centers. And promoting volunteering, that's another major area. A lot of volunteering services you can get in the aging related things, and dementia care services that I will tell that it can become a gold mine if you invest very well in dementia care skills. There are challenges, especially the death of the spouse. It creates a lot of imbalance, and we see that a lot of gender related issues in this area. And the cognitive impairment, I just mentioned, delay in seeking mental health care can be a disaster for family. Like I have my own personal experience where one of my close relative did not take treatment, and almost they suffered 1 to 2 years, the visual and auditory hallucination, and which disturbed the sleep of the family caregivers. Later they asked me, is there any solution in your mental health? I told there are some solutions. They took the both medical and psychosocial care, and the person continued their life for another 6 years. The person was bedridden and was disrupting the sleep of other family members of visual and the delirium, visual hallucination, and auditory hallucination. But with the medication and other support, the entire things have come down. And the 6 years they could care the person at home. Multiple hospitalization before the treatment. After the hospital treatment, only one hospitalization the following 6 years of the life of that person. So that's the importance of the early treatment. So you may be also interested to know that what I did, or what we are doing, our team is doing. So while I joined this institute, we started with the age-friendly Karnataka initiatives along the one of our Dr. P.T. Shivakumar only started, and I was invited to associate like a co-investigator. So this program was in association with the Karnataka State Legal Service Authority. So they had given some 27 lakhs for this program. And later it became like partnership between NIMHANS and Karnataka High Court. And many of these people who were associated became Supreme Court judges now. So very, very excellent experience during this interaction between hospital, legal service authority, court, and all other government missionaries. How it is important is once the court involves or the legal service authorities involve any programs, naturally the state IAS, IPS, and other cadre of the people will be active, proactively ensure the support. So this wherever you can try. We have done in Karnataka. It was a very pleasant experience in my entire career. So I recommend you can experiment in wherever you are. And second thing is the sensitization program on the maintenance and welfare of parents and senior citizens. Here also we got options where this was NIS, the National Institute of Social Defense supported. And this was I have taken initiative where we could see that we went around Karnataka, like Bangalore, Mangalore, then Belgavi. Then we went there and along with the support of the police, court, and senior citizen forums, and we could hear people. And we understood that there's a need for a lot of care resources. So this was the outcome of that project. The another thing you might have already seen in our Google and other our channels, Facebook and all, Vayo Manasa Sanjeevani. And that Vayo Manasa Sanjeevani, that Vayo is personally my contribution. Manasa Sanjeevani was the program they were planning for elderly. Then I thought we'll put Vayo also. So it has become Vayo Manasa Sanjeevani. You can see that Vayo Manasa Sanjeevani. 3 words. First word is psychiatric social workers contribution. As a beautiful all-enduring led program, online program. This proposal while writing also I was with Dr. P.T. Shumar. He is the one who is leading. Our Geriatric team lead in NIMHANS, and Dr. Tirumurthy, Tirumurthy, you know that, our senior professor of, he is also leading this program. A kind of more of a love, it has graduated to the next level. With less support, volunteers are running this program. And we also have kind of others in Mangalore and other region. They have already adopted this program. Basically, in this program, senior citizens come together. We learned over the period, like just telling about what is depression, what is anxiety, what is dementia, and why these family relationships are important doesn't help. One of the get-togethers associated with this program, people told it's boring, sir. Your sessions are very boring. We are elderly. We do not want this kind of lecture series. Can you arrange recreational programs? So if you see the Vaya Manasa Sanjeevani, you can, the YouTube channel, if you can see that, we have recreational programs, talks by the different specialists, and then a lot of caregiver support kind of activities, discussions, panel discussions, and then experience sharing and things like that. And this is recommended by Alzheimer's Association also. So they say that the world of caregiving is not known properly to the clinicians, and partnerships are important for us to understand. This is another program, All India's training program. It's going well. Now we got a grant by around 25 lakhs from ICAC Securities, where we are planning to train 200 all Indians. Like they will come and stay with us briefly in our hospital, and then they go and do the outreach program. And we have labeled, that's the program is labeled now Alzheimer's Seva Project. So the last one. And then the care workers training program, that was again supported by National Stock Exchange. They have given around 1.3 crores rupees for that. Then the Dementia Care Center is one upcoming project, and it is supported by around 10 crores by the rural electrification things. If I'm telling all these projects, not just to tell that these are the money has come to our institute, but the importance you need to understand all this program, social work inputs are there while planning the project, or while applying the project, or while implementing the project. Some projects we could lead it. And these initiatives are mandatory wherever we are. Along with the clinic-based intervention, community-based interventions are the building link between the clients and hospital system, between the resources and hospital system, and among the care providers is one of a major role for us. And our research, like the research which I am quoting only where I could associate, these are the doctoral studies, the training old age home staff, management of wandering behavior among elderly and dementia, adaptation needs of elderly living in old age homes, online support group and its feasibility, participation in social activities and level of loneliness, grandparenting, and the COVID-related many studies were there I have not listed. Few studies, few studies were there, like impact of COVID on elderly and things like that. The way forward plan 2, I could previously 2 slides ago, I told way forward 1. Way forward 2 is plan activities for stimulating physical activities and social engagement. A famous Harvard study says that sitting is more riskier. Sitting simply without any activity is more riskier than smoking. So that's what their regression analysis showed. So that means how much we can help elderly to be physically active, that much it reduces their both the physical discomfort as well as the mental health issues. And social engagement also equally matters. The social engagement, how it helps. Once you are socially engaged, there's a chance for a lot of problems will be there in your life. Then you get chance for planning for problem, so thinking about solutions for problems. That can indirectly stimulate and activate their cognitive functioning. The cognitive stimulation therapy or programs, if you just allow the elderly to mingle with others, a lot of these kind of cognitive stimulations they will get it. And finally, the way forward, another thing is palliative care associated plans and resources. You can be the specialist in palliative care, especially the end of the life care and the resources building. That also will be very rewarding. And people simply do not know what to do. They're ready to sacrifice their own assets, resources for the well-being of elderly at last moment. You know that how much money we spend for health care of elderly. But at the same time, some point they will come to know nothing works now, some kind of palliative movement. So with that, let me conclude my session.